At first glance, all of these disorders may seem disparate, unrelated, and perhaps even a little intimidating as a group. But it turns out there's one simple unifying principle that ties them all together into a single family. Every one of these disorders is simply just a way lung tissue may respond after being insulted or injured. The lung is a delicate organ with a fine microstructure that consists of 4 elements: tiny bronchioles, alveolar sacs, microvasculature, and interstitium, the scaffolding that holds all of this gas exchange machinery together. There are many things that can potentially injure this delicate microstructure, and these can be fundamentally boiled down into 3 categories: drugs, collateral damage from immunologic responses, and inhaled irritants. Both therapeutic and illicit drugs can damage the microstructure of the lung. 2 common examples of therapeutic drugs that can injure the microstructure of the lung are chemotherapy agents and amiodarone, while 2 common examples of illicit drugs that can injure the lung microanatomy are crack cocaine and heroin. Collateral damage from immunologic responses within the lungs, both immune-mediated ones and autoimmune ones, can also damage the lung's microstructure. Common examples of immune-mediated responses whose collateral damage can injure lung include the body's response to a viral infection, transfusion reactions, graft versus host disease, and chronic lung rejection, while common examples of autoimmune disorders that can injure lung microstructure include collagen vascular diseases and pulmonary renal syndromes. When it comes to inhaled irritants, we can divide these according to the 3 phases of matter: inhaled solid irritants, inhaled liquid irritants, and inhaled gaseous irritants. Inhaled solid irritants can be further subdivided into organic ones, inorganic ones over 1 micrometer in size, and inorganic ones under 1 micrometer in size. 2 common examples of inhaled solid organic irritants that can injure lung include mold and particles associated with bird droppings and feathers. 2 common examples of inhaled solid inorganic irritants over 1 micrometer that can injure lung include asbestos and silica, while 2 common examples of inhaled solid or inorganic irritants under 1 micrometer that can injure lung include soot and titanium dioxide. Common examples of inhaled liquid irritants that can injure lung are gastric acid in the setting of aspiration and liquid aerosols used in vaping, while common examples of inhaled gaseous irritants that can injure lung include chlorine and ammonia. Last but not least, it's not uncommon to occasionally encounter a certain number of lung injury cases where the cause is not readily apparent, at least based on our existing diagnostics and knowledge. We label these cases as idiopathic. Any one of these insults may injure the bronchioles, the alveoli, the microvasculature or interstitium of the lung. And injury or an insult to each element is tied to specific injury response patterns. Let's start by taking a look at insults that predominantly injure the bronchioles. And let's take a longitudinal cross-section through the bronchial illustration here. In some patients, inflammation and fibrosis within the subepithelial layers of the bronchiolar walls may result in progressive narrowing or even obliteration of the bronchiolar lumen in a disorder we label constrictive bronchiolitis. Constrictive bronchiolitis is an airflow limiting condition which may be visible on CT as air trapping or a mosaic attenuation pattern that may favor the upper and middle lung zones or exhibit no zonal predilection at all in the coronal plane. With regards to the axial plane, air trapping and mosaic attenuation pattern in the setting of constrictive bronchiolitis tend to exhibit no zonal predilection. The distribution of air trapping or mosaic attenuation pattern in these zones may appear either uniform or non-uniform. In some patients, a T-cell mediated immune response to inhaled organic antigens may cause inflammation within the peribronchiolar tissues around the bronchioles that may lead to narrowing or obliteration of the bronchiolar lumen in a disorder we label hypersensitivity pneumonitis, or HP. In HP, peribronchiolar inflammation may contribute to a centrilobular interstitial pattern on CT, while the obstruction of airflow may contribute to air trapping and a mosaic attenuation pattern on CT, just as in constrictive bronchiolitis. The imaging features of HP tend to favor the upper and middle lung zones in the coronal plane and exhibit either no zonal predilection or favor centrilobular lung in the axial plane. The distribution of imaging features in these zones may be either uniform or non-uniform. In some patients, injury to the alveolar epithelium may occur, which triggers leakage of fibrin-rich plasma into the alveolar spaces, followed by fibroblast proliferation forming fibrin plugs in a disorder we label organizing pneumonia, or OP. In OP, the fibrin-rich plasma in the alveolar spaces contributes to the appearance of ground glass lung opacities on CT, while the fibrin plugs contribute to the appearance of consolidation. OP is often reversible with corticosteroids. The imaging features of OP tend to favor the middle and lower lung zones in the coronal plane and peripheral or peribronchial lung in the axial plane. The distribution of imaging features in these zones is usually non-uniform. In other patients, severe injury of the type 1 pneumocytes in the alveolar epithelium and injury to the capillary endothelium result in leakage of protein-rich fluid into the alveolar spaces, in addition to an accumulation of cellular debris in the alveolar spaces and hyaline membranes composed of necrotic type 1 alveolar cells and a proteinaceous goo along the inner surfaces of the alveoli. In cases where lung repair goes awry, fibrosis may subsequently occur in a disorder we label diffuse alveolar damage, or DAD, which is the histologic correlate of ARDS. In DAD, the protein-rich fluid in the alveolar spaces contributes to the appearance of ground glass opacities on CT, while the cellular debris within the alveoli contribute to the appearance of consolidation. The imaging features of DAD tend to exhibit no zonal predilection in the coronal plane and exhibit either no zonal predilection or favor dependent lung in the axial plane. The distribution of imaging features in these zones may be either uniform or non-uniform. In some patients, injury to the capillaries results in leakage of protein-rich fluid into the alveolar spaces in a disorder we label acute permeability pulmonary edema. In acute permeability pulmonary edema, the protein-rich fluid in the alveolar spaces contributes to the appearance of ground glass opacities or consolidation on CT. The imaging features of acute permeability pulmonary edema tend to favor the lower lungs in the coronal plane and exhibit either no zonal predilection or favor dependent lung in the axial plane. The distribution of imaging features in these zones is generally uniform. In other patients, injury to the capillaries results in leakage of red blood cells into the alveolar spaces, or alveolar hemorrhage. In alveolar hemorrhage syndromes, the red blood cells in the alveolar spaces contribute to the appearance of ground glass opacities or consolidation on CT. These imaging features of alveolar hemorrhage syndromes tend to exhibit either no zonal predilection in the coronal plane or favor the mid and lower lung zones. In the axial plane, imaging features may exhibit either no zonal predilection or favor central lung zones. The distribution of imaging features in these zones may be either uniform or non-uniform. In some patients, chronic microinjury to the interstitium leads to aberrant repair, resulting in patchy interstitial fibrosis and architectural distortion in a disorder we label usual interstitial pneumonia, or UIP. In UIP, this patchy interstitial fibrosis contributes to the appearance of a reticular interstitial pattern on CT and honeycombing in advanced cases of interstitial fibrosis. The imaging features of UIP tend to occur in the basal lung zones in the coronal plane and in the peripheral lung zones in the axial plane. The distribution of imaging features in these zones is generally uniform. In other patients, diffuse and temporary uniform interstitial inflammation and/or fibrosis occur in a disorder we label nonspecific interstitial pneumonia, or NSIP. In NSIP, the interstitial inflammation and fibrosis may contribute to the appearance of ground glass opacities and a reticular interstitial pattern on CT, respectively. Unlike UIP, NSIP tends to preserve lung architecture and may improve with treatment. The imaging features of NSIP generally appear in the basal lung zones in the coronal plane and in the peripheral lung zones in the axial plane. The distribution of imaging features in these zones is generally uniform. Let's put some names now to the placeholder labels from on our earlier slide. Now remember that the insult leading to the lung injury response patterns here may potentially be anything on this table from earlier, and that the relationship between any of the insults in the left column and any of the disorders in the right column is usually not one-to-one, but rather multifactorial. So for example, let's take constrictive bronchiolitis. Constrictive bronchiolitis occurs in the setting of bronchiolar injury, and the cause of bronchiolar injury is not just one, but potentially many of the insults on this table, with the exception of inhaled inorganic particles over 1 micrometer and inhaled liquid phase irritants. If we take a look next at hypersensitivity pneumonitis, it turns out that the potential insults that can lead to HP are fewer, predominantly drugs, inhaled organic particles, and certain inhaled gases. If we go through each and every disorder, we can construct a summary table that looks like this, which summarizes the relationship between different insults and different lung injury response patterns. A few takeaways from this table. As classes, both therapeutic and illicit drugs are linked to every one of the lung injury response patterns we've reviewed. That means that whenever someone speaks of drug toxicity or drug-induced lung injury, they could be referring to drug-induced constrictive bronchiolitis, drug-induced organizing pneumonia, drug-induced diffuse alveolar damage, drug-induced usual interstitial pneumonia, and so on. The association with autoimmune disorders and idiopathic situations is nearly as strong across the board too. Consequently, if someone were to take any lung injury pattern and ask you to name several potential causes in conference, you'll usually do pretty well starting off by just guessing therapeutic drug-induced lung disease, illicit drug-induced lung disease, autoimmune disorders, and idiopathic. Now let's assemble a bird's eye view of the imaging presentations of these lung injury response patterns. What are the main takeaways from this table? 1. The common theme in bronchiolar injury response patterns are air trapping and mosaic attenuation pattern. 2. The common theme in alveolar and in microvascular lung injury response patterns are consolidation and ground glass opacities. 3. The common theme in interstitial injury response patterns is a reticular interstitial pattern. When it comes to the geographic distribution of these imaging features in the axial plane, it turns out that a diffuse axial distribution of imaging features is not terribly specific. On the other hand, A centrilobular distribution of abnormal imaging features in the axial plane tends to favor HP over the other lung injury response patterns, while a multifocal peripheral and peribronchiovascular distribution favors OP. A dependent distribution may favor DAD and acute permeability pulmonary edema, and a peripheral distribution favors UIP and NSIP over other lung injury response patterns. And guess what? We've actually been preparing you to handle all of these diagnoses all along since our introductory round of chest radiology essentials lectures. In our essentials talk on mosaic attenuation pattern, for example, we prepared you for diagnosing constrictive bronchiolitis and HP. In our essentials talks on consolidation, we prepared you for diagnosing organizing pneumonia, diffuse alveolar damage, acute permeability pulmonary edema, and alveolar hemorrhage, just like we did on your ground glass opacity essentials talks. In our essentials talk on reticular interstitial patterns, we prepared you for diagnosing usual interstitial pneumonia and nonspecific interstitial pneumonia, just as we prepared you to diagnose hypersensitivity pneumonitis on our essentials talk on centrilobular nodular interstitial patterns. In other words, it turns out you're already set up well for including these lung injury response patterns appropriately in your differential diagnosis when interpreting chest imaging. Except now you might just have a little better idea why these particular disorders appeared in the frameworks you committed to memory after our chest radiology essentials talks. And for internalizing these disorders, remember to think of lung injury response patterns in 4 categories based on the element of lung microanatomy being injured, and do your best to commit 2 disorders for each category. Now, since you've stayed to the end, I have a little bonus material for you. For day-to-day work, I usually suggest you to conceptualize lung injury response patterns as this convenient collection of 8 disorders. However, there's 2 additional lung injury response patterns out there that are uncommon. An alveolar injury response pattern named chronic eosinophilic pneumonia and a vascular injury response pattern named pulmonary veno-occlusive disease. In a very small number of patients, the immune system sends large numbers of eosinophils into the alveolar spaces in response to an insult, and these eosinophils fill the alveolar sacs with protein-rich fluid in a disorder we label chronic eosinophilic pneumonia, or CEP. In CEP, the dense eosinophilic fluid filling the alveolar spaces contributes to the appearance of ground glass lung opacities and consolidation on CT. CEP is usually highly responsive to corticosteroids, though if untreated, fibrosis may occur. The imaging features of CEP tend to favor the upper and mid lung zones in the coronal plane and the peripheral or peribronchial lung in the axial plane. The distribution of imaging features in these zones is usually non-uniform and multifocal. In an even smaller number of patients, an insult may lead to obstruction of small pulmonary veins, which result in post-capillary pulmonary hypertension and pulmonary edema when engorged alveolar capillaries begin to leak fluid into the alveolar spaces. If allowed to continue, pulmonary arterial afterload also increases in a disorder we label pulmonary veno-occlusive disease, or PVOD. In PVOD, the post-capillary congestion contributes to the appearance of a centrilobular interstitial pattern on CT, while the secondary pulmonary edema may appear as ground glass opacities, consolidation, and interlobular septal thickening. In patients with chronic increased pulmonary arterial afterload, the pulmonary artery will also appear enlarged. The imaging features of PVOD tend to exhibit no zonal predilection in the coronal plane or favor the mid and lower lung zones. In the axial plane, imaging features may either exhibit no zonal predilection or favor a centrilobular pattern. The distribution of imaging features in these zones is generally uniform. CEP has been associated with therapeutic and illicit drug exposures and the body's response to some viral infections. PVOD has been associated with drug exposures, the body's response to some viral infections, graft versus host disease, and autoimmune disorders. Occasionally, some PVOD cases may also be labeled idiopathic. The imaging features of CEP mirror those of OP. The imaging features of PVOD include the boxes checked in this table, in addition to a septal interstitial pattern and pulmonary arterial enlargement. Thank you for staying to the end.